Hello and welcome to the Geeky Medics podcast, the first episode of the new year. My name is Josh Chambers, a medical student at the University of East Anglia, and this podcast, selfishly, gives me an excellent excuse to interview really interesting doctors and healthcare professionals from a range of backgrounds, drilling down to why they chose the speciality they're in and what it's really like to do the job. In this episode, we're concentrating on palliative medicine, where I spoke to Dr Philip Wilkins, a consultant in the speciality, and asked him what it's really like to be a doctor in the field and where the future of the speciality is heading. I hope you enjoy. Thank you, Dr. Wilkins, for joining us on the podcast. So I thought it would be really interesting just to know more about palliative medicine as a speciality, as I don't think there's a lot in the undergraduate curriculum on it. I mean, there is at UEA, of course. But I wondered if you could give the people listening to this podcast an insight into palliative care. And first off, what sort of is a typical week for a palliative care consultant?
Okay. So if I talk about typical week, I mean, I don't think it's what a lot of people think it is, because certainly the general public think it's all death and dying. And obviously, a large proportion of my patients are in their last 6 months of life, and so we do deal quite a lot with that. But most of it is actually trying to optimise time for people. So I'll see people to manage bizarre and difficult symptoms and things which are troubling them, but we also get very heavily involved with trying to manage how a family is dealing with things, and how also supporting other professionals in how they're dealing with what is a very emotional and very distressing time for everybody involved. We cross a lot of different areas, so it's not just we work in acute hospitals, in community hospitals, in the community itself, as well as specialist settings like hospices. So we are heavily involved across quite a lot of areas. We're getting involved much earlier in diseases, and the whole term palliative has gone from something which, when you mention it to a patient, they look completely blankly at you and don't know what it means at all, to now people think palliative, that means I'm dying imminently. What's going on? What have the other doctors not told me? So again, we're looking at the terminology of it, because we're getting involved much earlier, and how we should be phrasing it, and how to be less threatening, really, because a lot of people are frightened of us.
Yeah, I mean, it's also understandable.
Yeah, understandably. Yeah. But usually so I have been involved just as the pain doctor. And once people then get to know us and realise actually we're just trying to help them and we're trying to improve things, they are much less threatened. So again, our hospice type setting is a unit called Priscilla Bacon Lodge, and historically local people have always thought, well, that's the place it's a one-way ticket, you never get out of there, you just go in and die. So nobody wants to come and see us in clinic. So we often get involved a bit earlier in the acute setting and things, and then often they're delighted to come and see us and realise it's not all about death and dying.
And in getting involved earlier, like you sort of mentioned, pain management, I mean, what other things are you managing earlier in patients?
So, I mean, again, earlier in disease it's a little bit nebulous, but what we've built up a specialty in really is improving symptom control and difficult, complex symptoms, trying to improve them. So we work alongside the teams who are improving the disease, and we're trying to improve how the person feels and their symptoms. So the classic thing is always pain, and pain is quite a good thing for people to feel less threatened by coming and seeing us, but we see all sorts of things like breathlessness is a really big problem that we get involved with, because again, often treating the underlying cause of the breathlessness doesn't necessarily make someone feel less breathless. And it's how to deal with that in a day-to-day life. So just about any symptom we can see. I mean, we get some of the slightly more unusual things like hiccups, which you think is just it's a bit of an annoyance, but if you're constantly hiccuping all day,
that is
for
the
months
thing
on
that's
end.
affecting their quality
That's
of life.
what's affecting them. And it's something which, again, if you look it up or do a Google search for it, you will come up with a whole load of old wives' tales as to how to treat hiccups, but you won't come up with something which concrete actually works for hiccups and things. So we do get some of the symptoms which people are sort of struggling a little bit with, and we will try and help with.
So what made you go into palliative care then? Was it something you always considered, or...?
It was a little bit of a roundabout route. It was not straightforward. When I was at medical school, I was determined I was going to be a surgeon, which is probably the polar opposite of palliative care. So I started off doing surgery, but I got disillusioned in the lifestyle. It was just hours and hours, constant work. So I then sat down and thought, what sort of patients do I like seeing? And what actually do I enjoy in day to day? And I thought I enjoyed seeing cancer patients. So I then went and looked at, I did a post in, it was 6 months of oncology and 6 months of palliative care, and enjoyed the palliative care aspect. It was a slightly unusual, because I was told at one of my medicine rotations, which to get my MRCP on that they're very different specialties, so you've got to decide which one you want to do is oncology and palliative care. So it was useful that I could do 6 months of each
And sort of decide.
And I was drawn much more towards the palliative care, and I think it's essentially you get the luxury of spending a lot more time and working out a lot more time actually what is important to people. You don't just have 5 minutes to sit there and say, right, we're going to sort out your jaundice or whatever. You get to, well, actually, what is the problem? Why is it affecting you? And certainly a lot of the people we see, we get referred for pain or something, and you find out actually that's the least of their problems. And you can achieve an awful lot for people. Because a lot of people think that palliative care is very depressing. And in some ways, I mean, all my patients do die, but what we achieve before we get there can be a lot more than in a lot of other specialties in my experience.
You say all your patients die. I mean, how do you sort of cope with that? I mean, the average doctor might sort of have one or two, whatever.
It is. I mean, obviously, I said it as a throwaway comment. It's not meant to be a throwaway comment at all, but it is something I think you do, because what surprised me a lot of the time is, obviously, we get junior doctors coming through our specialty, and again, I think because I do it day in, day out, what often surprised me with the junior doctors, what they can cope with all the complex symptoms and managing and doing that. It is the psychological aspect that they struggle with, and the fact that all the patients, however much effort you're putting in, they're getting worse and they'll die. And that's what most of the people seem to struggle with, and that's what the colleagues struggle with is the emotional and psychological aspect of constantly seeing people dying. I think everyone has to approach it differently. My approach is to be completely different outside of work and do lots of other things outside work and just have time to just completely forget about it all. It is an important aspect, and it is something that I say you just have to find ways of dealing with that, because you can't. It is a constant feature. You can't get away from it. And all specialties will have distressing, upsetting people and people who are going to die. But I think the problem with palliative care is it's sort of concentrated. And we also get the more complex ones, so the people that other people are struggling with, they ask us to help with. So we get concentrated all the more distressing and difficult ones.
You mentioned there about actually how you got into it, but also about junior doctors and the specialty. How do people go about sort of moving their way into palliative medicine, or if they're interested to try it out? Or
there's certainly. I think it's getting easier. I think to get into it, because certainly again, in medical school we didn't have anything to do with end of life care or palliative in any way. Whereas, as you say, now the guidance is that all medical schools should have a certain length of time doing palliative care. So hopefully people are exposed to it to sort of see what it feels like. And although I'm not aware of it, I mean, certainly not locally, and I'm not aware of anywhere where sort of F1 and F2 years it involves palliative medicine, we are very open, and I think most areas are very open to, in taster weeks in your F1, to come and spend some time with us and see what it's like and whether it is what you think it is. And the other thing is then it's obviously the way things used to be structured. It was quite difficult to work out how you're going to go into things, but basically with the CMT and then the ST training, you can very easily go from CMT to looking for an ST post. Part of the downfalls to that, in my opinion, is, again, I don't regret doing my surgical time. No. I think palliative care is something which, the more different specialties and the more experience you've got of different things, the better it will be. Whereas I'm a little bit worried that you can get just sort of channeled into palliative care now and not have the knowledge of what the day-to-day things are like on a surgical ward or a medical ward, and equally how other specialties might deal with the symptoms that we're dealing with. Because quite often we're tempted to manage the pain in certain ways, but actually sometimes it might be useful to see an alternative approach and speak to colleagues about things. But I think there's increasing ways of trying to get into it, but I would, if there are juniors who are interested in it, what I would recommend is just speak to your local team. Yeah. Because most people usually suggest that most palliative care physicians are reasonably friendly and will speak to the job. It should come with it. So most of us will, and historically, again, it's been a bit of a Cinderella specialty. I mean, certainly when I was training in registrar posts, that it was sort of looked down on, and it was not really a proper specialty, and you don't really do any proper medicine. You just so. I mean, it's quite. We're very open to people, enthusiastic people coming to us and joining us. So. Yeah,
I mean, it's a new speciality, relatively. Cystic Saunders and what she did and things. What do you think the future of the speciality is moving forward? I mean, you mentioned earlier about seeing patients earlier.
There's
a name change.
There's there are changes in there. So, I mean, some of the name changes, as I say, in terms of what palliative care is, there is this fear that people are frightened that it just means that you're dying. So some units are changing to supportive care and looking at more at wider things and earlier in diseases. We may even, which goes against a lot of what we do, because we're getting involved with lots more diseases and lots more different types of diseases. We're also, I mean, one of the areas which I'm currently looking at is what's called transitioning from pediatric services to adult services, because there's a whole host of diseases which traditionally were life-limiting within childhood that now children are living into their adult years, and there isn't really a service for them when they're adults, because they're often they don't fit into one nice different specialty. They have lots of needs. They are still going to be life limiting, but we don't really know how long they're going to live for. They've got lots of problems, so it's looking at that. And I think there's going to be lots of different working, so with things like that, with things like neurology and working with that. The difficulty could be that we end up just being this sort of nebulous thing that you don't really quite know what it is. So I think, ironically, there may be quite a bit more specialisation in the future. I think we're also going to get more and more involved with, we're already quite heavily involved with the ethical side of things, which is a big part of what we do. And I think there's going to be lots of change with that. I think it's only a matter of time before euthanasia becomes legalised, and I don't think anyone's thought through how you do it and what the implications are. So I think there's going to be a lot of different areas going through as to what we're going to be specialising in.
I mean, euthanasia. I mean, you actually, I had never even considered it, but of course, I suppose you would be the speciality.
I think so. I mean, it's difficult. I mean, obviously, we are the specialty which gets it, along with obviously general practitioners. We are one of the and we're one of the specialties which it's a constant feature of what we're doing, and obviously we get a lot of people saying, "Oh, you wouldn't let a dog suffer like this."
Patients say it all the time.
All the time. It's usually relatives that say it all the time, but also patients do it, and you do get people asking, "Can't you just finish me now?" and things, and so we do have ways of approaching it. I mean, certainly the whole thing is such an ethical minefield and trying to safeguard vulnerable patients, that actually as a palliative care physician, it is incredibly useful that it's illegal, because it opens up how you discuss about it, and you can talk through about it and why do you feel that your life is not worth living. But I think the whole position is going to change, and I just don't know what that opens up for the future as well. I think that's a whole thing.
That's a whole nother podcast. You, obviously, Cicely Saunders she was trained as a nurse, as a social worker, as a doctor. What type of person should go into palliative?
I mean, again, what obviously most specialties regard themselves as multidisciplinary and co-working. Constantly, when we are getting students through with us and junior doctors through with us, they regard, actually we do work multidisciplinary much more than a lot of specialties. So you do have to be able to work with colleagues, liaise with colleagues, both in different disciplines, but also in different specialties. We have to work well with all our colleagues across the acute trust with GPs. So you do have to work well with colleagues, even ones who you find difficult to work with. You also, I think, it's a specialty where, say, you spend a lot more time with the patients and their relatives, so you do have to be comfortable talking about things which actually that person doesn't want to talk about, and you do have to be able to in non-threatening ways discuss with people. So if you don't really like the aspect of communication skills and things, it's not for you really, because that is a massive part of what we do. And I think it's hard to know, because I would never sort of want to say, you only do this if you're doing that, but if you look at palliative care physicians, they are a very, very diverse group. And they've all come in from different angles, but I'd say it's probably the working with colleagues and spending a lot more time with patients, and it's also the trying to get over the be all and end all is not sort of curing the disease, and is not fixing whatever the problem is, because most of our patients we can't fix them. So it's accepting, I can't stop this cancer getting worse, and accepting that that's not the whole emphasis. The whole emphasis is, okay, this person's disease is terrible, their life is terrible as well, and they've got lots of other problems. How can we improve this as best we can, and trying to make the best of.
What sort of tips would you give to junior doctors working with families and the patients when they're in this in this time? Like you said, that is a huge bit of your job, and it's really difficult.
Because I suppose what often the biggest hurdle to stopping you doing all these things is several things. One is time. And as a junior doctor, you're always worried, I've got hundreds of other things I can do. If I start talking to them about the pain or something, I'm going to be here for hours and hours. And I haven't got time for that, so I'll just quickly skip over. Another one is, I'm going to get this wrong. and I'm going to make it worse, and it's going to be terrible, and if I say the wrong thing, it's going to make it worse. And there obviously are lots of other things, but they're the two big things which I think they're both wrong. So that as a junior doctor, yes, you've got lots of things, you're being bleeped to go and do hundreds of other things at the same time, but it actually doesn't take as long as you think it's going to if you do it properly and if you do it openly, and it saves you time in the future. So it's always worth doing it and just generally being open with it. And the other thing about I'm going to get it wrong and I'm going to make it worse, actually you don't. If you're approaching these difficult things that the patients are frightened of and scared of, obviously you don't want to be flippant, you don't want to make it look as though the person is bad for talking about all this. If you are just doing it in a very open and honest way and saying, well, I'm not sure, but I wonder whether this might be helpful, and can you tell me and show a genuine interest in things, it will always go well. It won't go how you envisage, and it may be uncomfortable while you're doing it, but the patients will be very grateful for it because they're terrified of it as well, and they want to have the conversation but don't want to have the conversation. So I'd say, if in doubt, just start talking and do it in a non-threatening way and very vague things to start with, because they will pin it down, and you will, as you say, if you do it correctly and you start with some non-threatening things to start with, they will get onto the topic themselves. They will
exactly what you said. I mean, they don't want to talk about it. I mean, it's not really as sort of junior doctor. It's not really it's not top of your, no. But it has to be done, and sort of to navigate that is really difficult. But I suppose.
But they're on. I mean, obviously, medical schools now do lots of communication skills, but it's not as difficult as you think it's going to be. As long as you don't sort of shut people up, you do actually genuinely listen to them, because basically they want to be listened to. So pick up on the clues that they're giving. Listen to if they'll say something quite subtle to start with that you think, why have they said that? It doesn't quite fit with what I've asked them about. Now, either they've misheard you, and in which case clarify, or they've said it for a reason, because they know that your time is precious, so they don't tell you things which are irrelevant. If they say something that doesn't quite fit with what you said, it's something that's important to them to pick up on it. You don't have to pick up on it straight away, you can come back to it and stuff, but listen to what they're saying and pick up on their cues.
As a junior doctor faced with things like this, before you phone the palliative care team, in the hospital, do you have any top tips in these initial stages, or is it phone the palliative care team as soon as possible?
I suppose it's difficult because, again, obviously, because we do an increasing on-call and we're doing things, then the worst ones for us are always the ones that it's usually sort of over the weekend in the night, and you get called about it, and this thing has been building up over days, and why didn't someone speak to us earlier? So yes, we do like to be called earlier, but equally the sorts of things which are useful for us and useful for the patient is making sure you have gone through everything beforehand. Make sure that you have looked at what drugs are there on, and could it actually be the drug that's the problem? Is it the right? If they're being sick or something, have they picked an appropriate antiemetic? So do a little bit of digging to start with and check, is everything that's been done up to now, is it the most appropriate thing, or are we missing something else? Do we need to be looking at something? Because again, I will probably be asking, what have you done about this? Why has gone on? And make sure you've got it clear in your head why it's all going on and why this particular problem's happening now. Because then you may find actually you think, oh, well, that's what's happened. I don't need to call them and work it out for yourself. So it's being, one thing we try and push as palliative care is being thorough and working everything out and looking at all the details as to why the problem's there. The other things we get called about obviously is distress amongst family and relatives and things. And again, some of that as a junior doctor may be outside of your ability to manage it, but the simple things again are not sort of to go head on but I know that I'm right, and you may be right, but listen to what people are worried about and what they feel is the problem and why they think that you're mistreating their relative or whatever and what's going on. Because again, a lot of the time it's they want to be heard and they're frightened and they don't understand what's going on, but you don't jump in and start explaining things. You listen to what the problems are, why they're worried about things, and then you can start helping. Well, why has it gone wrong up to now, sort of thing.
Brilliant. Well, I have no more questions for you. Thank you very much for joining us on the podcast.
Thank you.
Thank you again for listening. If you enjoyed the podcast and want to hear more from us, please consider subscribing through your podcast provider. You can also follow Geeky Medics on Instagram, Twitter and Facebook. We'd love to hear from you with suggestions on whom you would like to hear from next. Thank you to the producers of this episode of the podcast, Alice Appleton and Dr. Lewis Potter.